Welcome, everyone, and thanks for joining us for today's session, the On-Demand ICU Future of Sustainable Rural Healthcare. Before we dive in, just a few quick housekeeping notes. This session is being recorded and will be sent to you after the webinar. The slides are available for download in the Hands Out section. Send in your questions via chat anytime during this webinar. We'd also like to invite you to VSee at HIMSS 2026 from March 9 to 12. We'd be glad to have you visit us and see our new robot and AI co-pilot. You can also explore more sessions like telenursing and AI doctor notes at vc.com/webinars. With that, let's get started. I'll now hand this over to Milton to open today's session.
Hey, thanks, Roma. Hey, big welcome to everyone. Start the new year. Hope you guys all had a great time in this. Today we have an extra special guest on our show today. I just want to say by the my name is Milton, the co-founder, CEO of VSee. And one of the reasons today I'm super excited today is I want to welcome our special guest, Bobby Shah, today. So Bobby is the CEO of DocBox and a health tech entrepreneur who spent his career rethinking just how to make healthcare accessible, even in the most extreme underdeveloped countries. He's built and scaled multiple extremely successful healthcare company, deployed solution in hospitals globally, and was recently named one of the 5 most influential healthcare leaders to follow. And again, where I'm on a personal level, I also glad to count Bobby as a personal friend. I know him for years, and I'm just super excited. Again, beyond all his, you know, business success in there. And something he might not know about him, fun fact is, so Bobby started his very first company on the back of a napkin in a cafe. So Bobby, tell me what's the story behind that?
Milton, first of all, thank you so much for this invitation. It's always great to see you again. So many years ago, my son now, who's 22, my wife went into labor and she had a traumatic event.
Mm,
She had a bad epidural. Upset me tremendously. That evening, I'm happy to be in the venue. A gentleman was sitting next to me and asked me, "Why do you look so sad?" I told him what happened. And he said, "This person sitting next to me is actually my father-in-law. He's actually an anesthesiologist." So he being part of robotics at a large company in the Bay Area, 3 of us sat there for 6 hours in this cafe, back of a napkin, and actually created the EpiSure syringe for epidurals. And that's how the journey started. So since then, my mission is a couple of things. One, I don't want anyone else to suffer how, my family member suffered. Number two, I have a very keen passion of providing access to quality solutions, devices in remote locations. So act locally, think locally, but being able to have a global outreach in terms of everything I do. So my journey has been that I travel a lot, spend a lot of time in rural areas. And then after that, we created a family of infusion pumps. Infusion pumps were recalled. So we created one of the most accurate infusion pumps. We grew that company in 49 months, worked out tremendously internationally. So it really is about increasing quality of care, providing access, really affordable, but also going to places where many organizations don't reach. And that's what is my passion.
That's fantastic. By the hope your wife did great. This is amazing inspirational stories. How about let's turn the floor to you. Share us about your vision for on-demand ICU, all the work you're doing, and then again that will open up the question for the audience.
I'd love to. Thank you. So I'm proud today to present DocBox. And thank you all again for being here, being available. I wanted to tell the story, and I want to share the story of a founder. Founder's extremely passionate lady, biomedical engineer, really driven to change healthcare. The organization started with her driving this towards the US military. So in the US military, our task was someone in the battlefield that is injured, maybe traveling 4 to 6 hours without human intervention. And during that journey, they're on maybe a medication delivery device or maybe a monitoring device. And someone internationally can monitor them in real time. Imagine that. The infrastructure you're dealing with, there is no infrastructure. The deployment you need is rapid. You don't have the luxury of understanding what medical devices you have. As well as that, you've got to be able to have a very light footprint, and as well, no company is going to be able to be authorized to send someone to install. So you're turning maybe a Dash tent into an ICU, a single unit, a school, it could be anything. And the fact of being rapid deployment is how the company started. COVID comes along, where there's chaos. And in COVID, it comes along, for the first time in history, not just the government, but also domestic and international has the same problem. Everyone is running for healthcare. Healthcare is bursting at the seams. There is chaos everywhere. How do you provide healthcare to everybody anywhere? So COVID came along and it really poured us out, and we started commercializing for the civilian market, domestic and international, rural locations. So as you can see on the third one, this is us in the ICU. We deploy in villages every day, rural communities every day internationally, really where there's no access, limited infrastructure, bandwidth issues, political issues, and we're able to do that in a very, very successful manner. So as we go through this, I want everyone to keep something in mind. Another person that's very personal to me, but let's call her Maria. Maria, 62-year-old retired school teacher who lives 90 miles from the nearest tertiary center, admitted to a rural ICU with pneumonia that rapidly progresses into respiratory failure overnight. Now, one of the things I want you to just have Maria in the back of your mind as we go through this. So what is DocBox? What did we actually create? What have we been deploying? What we have built is an augmented intelligence platform. Now, for those of you, definition, what is augmented intelligence? Our platform is clinical infrastructure. It's very important to understand this. Clinical infrastructure that enhances human judgment. So we're delivering right data, right context at the right time. Most importantly, you're keeping clinicians in control. With augmented intelligence, you're able now to layer on top of this AI. AI without right data, right context, right time is a challenge. Many AI today, as you all know, is developed on synthetic data. Here is the first chance to get actual real contextual data. So what has Maria got into today? We're talking about over 300 parameters on a patient every day. We're talking about nurses spending 40% of their time documenting, not being able to spend time with the patient, clinician-nurse interaction, maybe looking at optimizing workflow. It takes it away. Revenue leakage is 40%, not just in the United States, it is global. 1% of hospitals actually write off their turnover because they do not have accurate documentation. We all know that COVID did one thing. COVID broke the mold in healthcare, and healthcare is looking for a partnership. And part of what COVID had done is it increased the burden of documentation that's required. 30% of EHR records contain errors, and it's human. We're all humans at the end of the day, and that's where we are. 5% of revenue is lost. This is mischarges, incorrect clinical decisions. It hasn't reduced since COVID, it has rapidly increased. We talk about workforce crisis, $12.4 billion annually. So clinical efficiency, this inefficiency is billions of dollars. We're talking about documentation errors. We're talking about fragmented silo documentations. We're talking about staffing crisis, shortage, burnouts, and this fragmented data. This is all across healthcare. Doesn't matter the structure, the size, or where you are in healthcare. So our mission and what's in our DNA, by creating this augmented intelligence platform, we have created the first vendor-neutral platform that connects up to 26 medical devices around the bedside. We're vendor agnostic. So I want you to think about this in verticals. Companies, do they integrate? They do. But when companies integrate at the bedside of medical devices, it may not be legacy devices. It may just be partner devices. Now, when they integrate, they were integrated in the purpose that it was for human vision, and that's natural. Clinicians would see it, they would read this information, and that's how data was collected. We now start to have intelligence layered upon that. So it's not so much for human, it's also in parallel. So we can start to layer intelligence above this. So DocBox unifies the data, standards, provides real-time bedside data, which is what we're able to do. In parallel, the nursing workflow sheet, with many of you are familiar with, and some of you even are documenting on paper towels, as I found out recently. It's real Post-it notes. That documentation is digitalized. That documentation, some areas, we reduce documentation by 70%. Other areas, it's totally paperless. Now think of this. You're adding real-time, contextual, standard-based data along with clinical data. With this, you're able to layer intelligence over this. But as well as that, what are you able to do? You're also able to have accurate costing, accurate billing, and an audit trail. So from that being said, we talked about automated data integration. There is a single pane of glass, which is a real-time clinical dashboard. Nurses are able to reclaim approximately 4.5 hours a day, that nursing documentation time. Augmented intelligence, very important. We talk about error reduction. We're humans at the end of the day. And now remote monitoring and tele-ICU. We're talking about having a command center. We're talking about the clinician of that command center seeing real-time data as well as video audio. Now you're able to have real-time care, which is what you're able to provide, just like you're at the bedside. And then we talk about revenue recovery. We are the only solution that exists that is positive cash flow from day one. And nursing retention and burnout. So you're reinvesting back into the nurses. So we're combining this human expertise with machine intelligence. We talk about speed, scale, precision, improving quality of care, reducing the number of bed days, reducing the cost is what we're talking about, and having not just better patient experience, but better clinician experience. And that's where we are focused. So with that being said, I want to pause. Very interested about this. I'd like to move to a poll. So everyone's seeing a poll. I'm very intrigued. So if up to 3 hours a day of nursing documentation time was returned back to the nurses, right? So we're talking about per shift, per day, how should that time be best used? Really intrigued, and they're coming through fast. We're talking about either spending more time at the bedside with the patients, safely manage a higher patient load, increase collaboration time with physicians. We're talking about improve quality workflow nursing systems, right? Reinvesting back into that. And I think the result is not going to be that much of a surprise to some of you, because we all know patients come first. Spending more time at the bedside with the patient is definitely the majority here, for sure. We want better patient experience, better patient outcomes, reducing errors. This is great. Milton, as you can see, I don't think you're surprised either by the poll that's coming in.
This an obvious, like I think by the it's quite incredible to the amount of hours you could save per day. This is like just absolutely incredible.
It is, and having clinical staff, nurses, this is why they entered the field. They wear their heart on the sleeve. This is why they entered the field, is for the patients. And by being allowed and enabling this to happen is priceless. This is great. So thank you. So that poll, 59%. I don't think anyone's surprised on that. So I'd like to let's talk about financial. And it's very important we do this, because this impact is what gets reinvested back into this. So with our solution, we have seen, without having included our solution, and this is what we do every day. Right? So we're talking about the impact, and on here, there are different personas, right? I'm sure that each one of these on the right-hand side, whether you're a CMO, CFO, CNO, and others as well, all staff can resonate with each one of these. We are talking about, we demonstrate reduction in length of stay. We demonstrate that. We're talking about improving bed turnover rate, adding incremental revenue to that ICU. Now, reduction in nursing documentation time, right? We're bringing that down tremendously. I mean, how many items are written down on a nurse workflow sheet? How much documentation is there? How much of that actually gets entered into the EMR? How much is not captured in that EMR? And it's not because there's no place to put it. It's time. It's time. Missed charges. What are the key things that are missed? Are ventilator start time, stop time captured? Is reintubation captured? Are ACT tests captured? Is changing of a vent setting, changing of a syringe pump setting? Are any of these? And we all know that the amount of claims that are denied due to incomplete documentation. And we all know the time that takes to recoup that cash flow due to incomplete documentation. And then reduction in readmission rate. We are talking about a patient-centric data is what we are talking about here. So with that being said, I want to pause on something. We've actually demonstrated that facilities are able, depending upon the facility, depending upon the volume of patient, they're able to generate $1 million per ICU on average per year. So with that being said, I want to pause. Another poll. Let's go to another poll, please. So which of the following would most improve patient care in your ICU today? Reduction in nursing time. We talked about reducing nursing time. That was very familiar with reducing documentation time, spending more time at the bedside with the patient, which came up in poll 1. Reduction in revenue leakage from missed documentation. Accurate coding by having the contextual data being available. Adoption of AI and analytics. Now, in order to adopt AI analytics, it's very important to have the right contextual data, right time, right structure. Remember, that's our augmented intelligence platform. We're an enabler. We partner with organizations that look to develop AI, that look to have business intelligence tools, that want to layer above the healthcare provider's augmented intelligence platform. And I think many of you have seen in January how the FDA has made a shift where instead of providing options, you can provide a single solution. There are many things that has occurred and is still forever changing as well, but also real-time bedside device integration. So we have two in the lead: reduction in nursing documentation time and adoption of AI and analytics. I want everyone to pause and think about something. What we have seen in rural areas, by reducing patient transfers, and that's important. As patients are transferred out, majority of that revenue is moving with that patient. The family members are moving and are getting further away from the patient. We're enabling in rural areas to provide an infrastructure. That infrastructure allows the patient to remain. That infrastructure actually starts to build you a critical care environment close to an ICU as you're going to be able to have in that area. The opportunity cost we've seen in some areas of keeping approximately 40 patients, it's almost $1 million you're able to recoup within that rural community. Now think about you're closer to your family members, which is also very important. So this has been a key aspect for us. So being able to have that information so that the patient transfer is not happening. Really, for us, we've really been very, very pleased to see that they can stay within that family member, within that ecosystem. Our footprint is so light, we can come down to systems that have single unit beds, which I mean is less than 10. That's we've been really successful. Some areas that have less than 5. Some have legacy devices. We build drivers in 30 days. So thanks to the US government, our DNA has really been about light footprints, rapid deployment, care anywhere, right? Irrespective of the hospital walls. So with that being said, I want to say thank you for that opportunity about us. And Milton, I want to hand it back over to you.
Hey, Bobby, that was really, really insightful. I appreciate your sharing work and amazing work. But the one thing you mentioned in your slide that you're able to reduce the mischarges, you're able to achieve a 40% reduction. Again, what needs to be done until you get like just 100%,
Yeah.
like zero mischarges?
So our key aspect in terms of mischarges, you have to have the combination of both accurate standardized device data.
Mm-hmm.
So for example, timestamped is very important, having that unified, layering that on with the digitalized nursing workflow that we provide, that combination together, everything from a changing an event setting to a reintubation, every procedure, every activity that happens to that patient is documented and can be used for billing, audit purposes, etc. So it's very important to have that. Now you're able to look at accurate CPT codes, etc., of what now needs to apply to that. Many of these charges are missed because of this gaps.
Okay. And Bobby, another thing is, I know you guys started from the military background, even I know within the Department of War, there's big push into these where because you can't get a clinician to the right place. How far are you guys with the industry from like zero nerds, zero physician to truly, because once you have the instrument, your AI are making these clinical decisions. Yeah. Again, I know this is not for the rural setting, but for the extreme setting, literally just like there's literally no one around.
Yeah, I mean, for us, the key thing for us is being able to provide an infrastructure for third parties, whether it be on the telehealth side or whether it be the the devices are actually by the bedside. So the clinicians now are able to see not just real-time data in some areas. We integrate into the EMR, but we pull
Yeah,
from the PACS. So Milton, you could be where you are right now. We could set
yeah,
up a command center. You could see 50 hospitals, 50
yeah,
locations. You'd be seeing real-time information from each of those devices, including waveforms. As well as that, there'll be bidirectional documentation. All of this will be fed into your
yeah,
HIS, your EMR. Right from where you are, you can actually make accurate decisions. During the COVID time, we actually was working through remote control.
yeah, yeah.
So remote
Yeah.
control, you're able to, from where you are, Milton,
Correct.
adjust
You can do it.
ventilator settings.
Yeah,
Those are things, and that's public information. People can go on and they can see what can be
yeah,
done for that. During COVID, there were 15,000 people, patients that couldn't decide, or that passed away because do you send them to where the skilled teams are or where the ventilators are,
yeah.
right? So it's very important to have this central command center.
Terrific. Bob, you have a question from Jack from the audience. He's asking, could DocBox be utilized by rural hospital in very low resource country, places like Kenya, Uganda, and so on? I know you're very active in India. I was curious, like how low resource like can you get to?
And Milton, you said that was from Jack.
Jack, yeah. Question.
Jack, thank you. Thank you for that question, Jack, and thank you for being here today. Jack, we actually install in extremely rural areas in India, in villages, which is what we install. Those villages have extremely old devices. That's the first thing. Some have devices that don't connect, but yet everything is paper today. So we start from the nurse workflows. Digitalizing the paper is where we start. They may have no more than 5 beds. We then, through the hub, they're actually being connected to a tier 1 city from this tier 3, tier 4, which could be 250 kilometers away. Now, one of the things that comes up, and Jack, you're most probably asking the question, I'll help you out, bandwidth issues, right? So you may lose audio, video, but you will not lose the data. And when it comes back up, that gets passed back as well, which is what that occurs. We're able to install these in less than 30 days. And that shows you how light the footprint is. And Jack, there is one aha moment out of many aha moments I had. And this is very important. This system was built by healthcare providers and a government. So I was in a rural facility. There was a nurse in that rural facility who had a flip phone, didn't have a computer at home, right? Hasn't used computers, used a paper and pen. After 3 90-minute training sessions, I saw her the next day. She was going through this like she'd been using it for a very long time. That's how intuitive this is. This is not for, it's just not for these large healthcare systems. This is for the places where they would not get access to this.
Yeah.
So we provide that infrastructure. Thank you, Jack.
Fantastic. By the way, Jack and I, we do quite a bit of work in Africa. I'm pretty sure he'll be calling you after this.
Fantastic. Okay.
Yeah, Jack is awesome. We have another question from the audience, Michael. So he's asking, have you integrated into Epic, Oracle, Meditech, EMRs?
Yeah. Michael, again, thank you also for dialing in. Very much appreciate it. We do. So we integrate into, and we are completing integrations in the US right now with Epic in 3 locations. And that's what we're occurring. We've worked through with Meditech as well. And internationally, we're working with some are homegrown. I would say they're built within the system as well. So we've been very successful in able to do that.
Great. He has a follow-up question, Michael. He's asking, and so for comparison with other products, like maybe some of your competitors, so how do you stratify charges, for your DocBox to your clients, to your customers?
That's a great question. So we're an OpEx business. So by accurate activity, accurate procedures, we're actually positive cash flow from day one. So in some areas where it's a license fee at the end of the month, the amount that they are recouping far exceeds the amount of the license fee that they pay. So it adds incremental revenue through to accurate documentation.
That's fantastic. I think, Bobby, one of the things what I like about your business, literally they're generating positive cash flow from day zero. It's not about
It's
spending money,
and
about increasing revenue. Yeah.
you know, Milton, when COVID was here, one of the things that we did as an organization is we made some assumptions as an organization, and the assumptions that we made was hospitals have, limited IT staff. They're under a lot of strain, a lot of pressure to implement. We've got clinician burnout, and shortage of staff. We've got infrastructure that is breaking at the seams, and we're very used to history spending 12 months to integrate systems, putting teams on it, having huge budgets for it. Those days have gone, to be honest with you. Now it's about taking healthcare outside the hospital walls. It's about providing care eventually in your homes. So when you escalate, maybe you skip the emergency department, where there's huge amounts of cost in that ED. And as well as that, we make the assumption that finance budgets in hospitals are scarce. So with that framework, how can we assist and provide a solution that is going to reduce number of bed stays, so increase throughput, increase quality of care, but reduce the cost dramatically. And adoption, we're not a burden for any facility.
Yeah.
So there's no out-of-pocket cost on day one.
Oh, that's fantastic. Yeah, yeah. I feel like an easy. This is so much too good to be true. We have another question from the audience, Lloyd. He's asking his congratulations, awesome presentation. He's asking, how do you handle the challenges in the last mile for rural ICU implementations?
So, Roy, thank you so much again for you dialing in. Very much appreciated. So we work very heavily on the integration side, and that's one of our key sweet spots, to be frank with you.
Yeah.
So we handle the mapping. It's very important for us to handle the mapping on here. We also provide drivers, which is what we do. If we don't have a driver, we build it. We have a vast array of drivers. It's consistently, we have a deep driver team, which is what we provide. We do a pre-infrastructure walkthrough with the teams within the facilities. So it's a seamless integration on every point. And we do it in phases. We start with bedside integration, which is the devices, adoption of the clinical workflow sheet. And then we move into PACS integration, we move into EMR integration. So it's very, very phased into it. Many facilities today are reverse engineering and building their own drivers, and there's more and more they're asking to implement, they're asking to scale. A lot of pressure is being put onto them to adopt.
Yeah, it's good that you have done all this work with the drivers, and now this is file. You can just do that quick implementation, right? It's no more engineering.
Yes.
So Bobby, so like in terms of for the rural hospital, what do you see the rural hospital losing the most revenue from the ICU related like today? And I guess how do you see maybe sort of tele-ICU, like what you're doing, able to maybe close those gaps?
So the ICU is one of the most expensive footprints, certainly that we see, within the environment. Let's call it critical care footprint. So one of the things from our side is, and there's a lot of frenzy. So we work very closely in providing contextual information. It's very important. The unified information is very important. Now, here's the thing. The facilities are able to collect 2 to 3 gigabytes of structured patient data per day per bed.
Yeah.
It's a huge amount, right? It's perfect when you're layering business intelligence and AI, above this. So within here, we work very closely, which is what we do. So when we are talking about how you're filling the gaps, you've got that consistent continuum of care. You've got that consistent documentation. You've got that consistent, as well as that every activity and procedure is itemized. You've got timestamps coming in. So if all of a sudden, Milton, you want to know what happened at 8:01 to the patient, it's very important that everything happens in a unified manner. So now when you're adding CPT codes, etc., we've got items that are not missed and ones that are not missed that are accurately coded.
Got it. Great. Then in terms of along the same things, like what's the typical common financial concern you hear from CFOs? Like I know that increasing revenue, a lot of things you're mentioning. Is there other things that you hear commonly from the CFOs?
They have their KPIs that they have to hit, right? And you're balancing financial with quality metrics, which is really important. So for us, because of really the main thing for them is having accurate billing that is not only readily available as real time as possible, but is also auditable to reduce the number of denials. It's really important, but also where they can start to look at quality improvements, where they can start to look at supporting the clinical staff for better clinical experience, where they can look for clinical workflow. So it's very important for them to start to first to have that as an understanding, and then start to look at how do you strategize that and reinvest that back into the system.
Got it. Okay. That makes sense. I have a question from the audience, Michael. He's asking, at the foreign sites, how do you overcome the language issues? Like, do you have like built-in translation into your tools? Like, how do you handle those?
So that's a great question. So, Michael, you're talking about integration of medical devices that speak different languages, etc., right?
Yeah,
And
or
that's
potentially it could be maybe on the foreign location side, maybe the patient, or maybe even
yep.
Yeah.
So that's a great question. So we deploy in English. Many of our requests internationally are English. We have been requested for other languages as well, which we are able to translate, and we work with some of those partners in terms of languages that we have to translate. For example, Spanish. Spanish is also a key requirement in a lot of key areas.
Yeah.
So that's a true partnership we have, but majority of the time we have seen the request for English, but language is not an issue when you're talking about on the UI side. Yeah. And key thing here is if you structure data correctly on both of those sides, laying the language above that with the right contextual partner.
Yeah, terrific.
Makes sense.
I have another, I guess, common / question from Jack. So he's saying, like, terrific presentations. Well, most of his effort I've seen developing a model in East Africa, where I work with Jack a bunch of time, So he spent a lot of time, but more recently, he spent a lot of time on the phone with his 89-year-old sister who spent the last week in a small town hospital in Minnesota where she developed unfortunately congestive heart failure. So he's asking, wondering like how much better would her sister's experience be, like if they have your system?
Jack, that's a great question. I'm going to tell you a similar story, and it goes along the same line. So, Jack, this will give you kind of like an understanding. So, here in the US, there's a gentleman, and one of the things I want people to realize is that sometimes availability of people in ambulances, paramedics, they have other jobs, and they're ready to go when aspects are available. So, for someone that has what we're talking about is your patient remaining in the location that they are in. We are talking about them being able to have their vitals monitored in real time at a hospital location. We are talking about earlier interventions able to occur. We're talking about, Jack, you may need to go find a nurse for your mother, and so all of a sudden you become that intermediary, you become that communicator, you take on that responsibility. But now all of a sudden you've got real-time monitoring anywhere, right? Whether it be home, patient-centric, and then you've got physicians who are able to monitor that in real time so they can make the correct clinical judgments in real time. Right? And that's the important here. So all of a sudden you're not saying, I need to now transfer. Let's go ahead and go to the local clinic. Let's go get, checked up, as happens with people's loved ones. Now you're having to do that, right? And take away. And here's a key thing. So in rural areas, what we have seen is, many family members have to stop their job. They have to go and take their loved ones, take time, take them over maybe 2, 3, 4, 5 times. Right? Now you're able to have them at home, have them comfort, have them surrounded by family, and have this monitored, even with medication delivery devices, right? They're on an infusion device. You can still keep them there, right? Rather than, okay, let me go find a nurse. Let's go schedule a time. Please tell me. I have seen incidences internationally where they've had to take photographs of different things. It's HIPAA compliant, but move that information that way across in order to make clinical judgments.
Yeah.
Jack, thank you.
Bobby, we have a question from Kim. So Kim is asking, most of the rural hospitals she has worked with, they're open to tele-ICU if they can easily transfer the patient when the care level is exceeded. Because typically, right, inpatient transfer is a lot harder than like ER transfer. And because of that, it's really scared the C-suite in there. Like, how do you address that?
Yeah, that's a great. Kim, thank you. Thank you for being here today. Very much appreciated. Kim, as that patient's transferred, the key thing is you want information to be transferred in real time along with that patient as they're in transit. They're going to want to ensure there's readiness, room readiness, preparedness at the receiving end. There are many times right now in transfer where data doesn't follow the patient. Room readiness is not available. It's done through phone calls. It's done through as the patient's transferring. You're speaking, you're seeing the vitals, etc., but that real-time information, is not installed. It's not going along with the patient. We've seen that to be very beneficial, which is what we've seen it. We've seen that to improve the quality of care on the receiving end, which has been really important. And then the time to transfer, the decision you make to make that transfer, that information is very, very important as well, of when you make that time to make the decision for transfer. Thank you, Kim.
Got it. Okay. Do you find that one is sufficient to convince these hospital administrator who might be reluctant to adopt your model, or you feel like they still need some extra push for them to feel comfortable? Because again, this model is quite a significant change from the like just patients show the ER, or like let's just send them out. Like, yeah.
So our model is broken down into phases, which is what it's done. We have what's called a virtual work list. And that virtual work list that we have deployed, so Milton, if you're sitting there, you'll be able to see multiple patients in different locations. you can then start to go in and access that bedside and pull all that patient information that you select in real time. You can start to see which are your sickest patients first, right? Key thing here for the administrators, what we have seen, certainly from the nursing perspective, is we want to reduce nursing documentation time. We really do. We really want to spend more time with the patient. What do we need to do in order to make that happen? That's a piece of the solution. We've certainly seen IT staff, reduction in IT staff, but yet they're having to adopt more and more technology. And that technology, infusion pumps, doesn't get fed into the EMR. There's been a real need for that in order to come in. So from the CFO's perspective, we've seen them being very interested on the revenue leakage side, but as administrator, the adoption of AI is very important, but the adoption of AI is very slow. And adoption of AI right now is outside of critical care mostly.
Yeah.
Right? Why? Because the barrier to entry into critical care is they need the augmented intelligence platform, that right contextual information. Right? This is kind of what they needed. And that's what we are providing to be an enabler on that. Right?
Yeah.
So you've got finance, contextual information. You're building this 2 to 3 gigabytes of structured patient data per day per bed. And now you're able to provide remote real-time data anywhere.
I think that's fantastic. One question I have is so how can the tele-ICU change the day-to-day workflow for the bedside nurse and clinicians? Again, I'm assuming as you mentioned, if fewer documentation to better decisions in there, can you maybe paint us a picture this? How does it work? Yeah.
So here's the first thing. One of the things is that we want to reduce nurse burnout. Okay, we want to reduce cognitive overload. It's very important. That's the very first thing that we want to be here, and that's the very first thing that we want to help with. One of the key things is by having information that wasn't available before, you're able now to start to really make clinical decisions at that bedside and spend more time at that bedside that you were not able to before. You're not rushing. And let's be frank, the number of patients that I've seen some of the nurses managing is unbelievable. It really is. My heart goes out to them. And yet they're supposed to provide the best quality of care for everybody, and they're doing the best that they can, right? But information is very important. And having that information there for them, they can make that real-time decision and be confident in making that real-time decision, is important in here. As well as that, the key aspect for us is, I will tell you something. I had a loved one that was in an ICU not too long ago. And I learned something all the time, and the nurses did not have time for lunch. Okay.
Yeah.
So the question came back is, I want to reduce nursing documentation time, but how do I do that if I don't even have time for lunch?
Yeah.
Right. So it's a real support function that they are looking at to come. So we came in and we showed a really easy side-by-side adoption of what occurs. We show that reduction, and then we showed what would you do with that information that you now have. It really, really was an eye-opener.
Okay, that's fantastic. So, Bobby, one of the things in the U.S., right, of course, there's that $10 billion per year rural health transformation fund. I feel like definitely every rural hospital, I feel like they gotta deploy a solution not tomorrow, but today, right? This is such a if you were to take one of these for, let's say, rural hospital that have very limited resource, right? From budget, from staffing, from IT support, you name it, the extremely resource constrained in there. Can you paint us a picture? What is a realistic tele-ICU rollout looks like?
So we have seen right now where in some of these rural areas, we have seen patients coming into the clinic where they are going straight to amputation.
Okay.
There has not been a stop in between. Why?
Okay.
Because by the time they have seen these patients, it's an emergency.
Mm.
From our standpoint, what we have been able to do and what we are working with is not only providing this infrastructure, right? So now you're providing a care system, a care group around you that works with you locally, right? You're talking about a hub and spoke model. We're talking about taking primary care, starting primary care out there in remote locations so we can feed into patients can escalate. They can start to see it early. But there's one thing that's really important about this. Rural healthcare has been a topic for decades. Now we've got this budget coming along. But one thing is, innovation is needed. As well as that, how are you getting access? How are you providing these patients coming in? And providing this care group that we provide with this infrastructure,
Yep.
You're now able to see more patients, which is what you're able to do. You're able to guide and see which patients need to come in. But there's something very, very important about all of this. And this is what I am extremely passionate about is at the end of the day, when all the funding ends, etc., how is this sustainable? That's what we really, really target here. So when we deploy in rural areas, you've got 300 people that are running to a clinic. That clinic is only open Monday, Wednesday, and Friday because that's all that they can staff. Now what we're doing is we're opening it up 7 days a week. We've set systems up in there that now they're able to provide through a hub model that care. You've got people going back to their homes, which is what you're going to, but also it's a sustainable model. So they can financially sustain themselves going forward, which is where we spend a lot of time with them on.
Yeah, I think that's fantastic. I think probably on a practical level, I guess I was thinking is like, is there do you have rule of thumb, okay, for rural hospital deploy a solution, they need like one IT person for how long? They just what, again, I'm thinking for these, again, very limited resource.
Yeah, so
what do they need to do in order to deploy your solution?
Great question. Yeah, great question. So remember, we started this as telling you our mandate was and our DNA was rapid deployment, limited infrastructure, limited staff, etc. Right?
Yeah.
So we work typically with, it could be a biomed and it could be an IT individual.
Okay.
Literally one. We take the burden off them, which is what we take. So that's where we talk about the mapping, the pre-installation walkthrough.
Yeah.
So we do that all in advance. We look at the devices that they have around the bedside. We have those drivers. So we can install a whole ICU literally in 45 days. That's what we're able to do. We're able to also work with the head IC nurse, which we're able to do, to show the clinical workflow sheet. And we work with them on that. This is a true, Milton, vertical drop-in solution to go live almost in real time zero as possible. We're not looking for a whole team to come in. We're not looking for a 12 months installation. We're not looking for any of that. It literally is straw staff that will work with us. And even on that, it's very limited.
Yeah.
And we had to do that. Yeah. That's the only way you can deploy in rural areas.
Yeah, that's just great to hear. I guess I know a lot of people in the audience on this show they're really interested in this tele-ICU, and a lot of them are administrator in their education. Maybe what are some common mistakes people make when they're going down tele-ICU? Of course, not with your product, with your competitor products. What are some mistakes you see people that they call you up to fix their mistakes?
It's a great question, right? Here are some of the aspects. So tele-ICU is certainly needed. It's growing globally. There is no doubt about that.
Yeah.
Many times it's reactive rather than proactive. which is true. It's also very expensive. It can be in other areas with others, right? From our aspect, what we have seen is it truly is a divide between providing tele-ICU and then able to provide real clinical data that feeds into the tele-ICU. At Milton, as you and I discussed, this is truly the first time that augmented intelligence is merging with tele-ICU, with virtual care, right? Now, as we've seen earlier in the poll, people are very interested in AI, so AI sepsis, right? For example, early detection, AI hemodynamic, ventilator weaning. There's so much now remotely that it's important in the direction of the way tele-ICU goes.
Awesome. So, Bobby, thank you so much for just teaching me a bunch of stuff. I'm pretty sure my audience, they have like a great time just hearing from you. So, you built a phenomenally successful company. So what's next for you? Like, what's to the extent, can you give us a peek into what's coming up?
So we've focused on our side because of the augmented intelligence platform and the contextual information that we have that others don't. It's opened up the door both internally for partnerships with facilities where we have and we're in the process of co-developing for them intelligence that layers on top of this platform, right? Many of these facilities are building now large data lakes, and this is great. It's great for their clinical trials. It's great for product development. It's great for layering business intelligence tools on there. So we're a partner. One thing COVID has taught, no one's looking for a vendor, everyone's looking for a partner. And we're a true partnership on that. That's what augmented intelligence has done. So between us internally and externally, you're going to start to see some really keen, needed augmented intelligence and AI that's going to be released, not just domestic, but also international. So we're very much excited about that, of what we're able to do.
Fantastic. And Bobby, maybe as we wrap up, maybe I ask you one final question in there. Of course, healthcare is all just like, it's all the news or politics in there. If you could whisper one idea into whether President Trump or RFK Jr., and what would be this one idea you're planting in their mind?
That's a great question. So one thing I certainly would say is allow technology to be adopted as long as they are hitting some key fundamentals. Open the door, embrace. There are some great technologies that are out there. It's a partnership, which is truly what that's enabling. So our goal is to touch 1 billion lives. That is DocBox's goal globally. And in order to do that, it takes a partnership. We're proving sustainability financially. We're proving access. We're reducing the burden. So for President Trump, support these organizations, embrace them, and that's what they need. Take the financial burden off the healthcare providers.
Yeah, makes perfect sense. Bobby, thank you so much, Bobby, for your insights into the future ICU, like all the stuff you accomplish, and you will also do just amazing. We hope to see these technologies definitely impacting rural health. On the personal level, I'm super excited. Our partnership, all the working together. And also, I want to just thank everyone for joining us this week. And we'll be sending out the recording and slides following the sessions. And definitely, you can feel free to reach out to Bobby. He's very easy to reachable. I'm pretty sure there's a bunch of collaboration with Jack, Kim, and so on that will be coming up. And if you are going to the HIMSS in March in Vegas, we definitely hope to see you there, and make sure to stop by our booth. Basically, we're going to be launching our robot again in partnership. We're going to roll this out blending with Bobby's solution again with a bunch of AI product solutions suite we're rolling out together. And finally, we're looking forward to you guys joining us on our next webinar Again, thank you, everyone. Until next time, really appreciate it.
Thank you all.